Hey guys, welcome back to the FOAMfrat podcast. Tyler and Sam here. Happy EMS week.
Happy EMS week.
I think Brian got a hold of the old company credit card and went a little nutty nuts with the giveaways. When I was looking at what we were doing on Facebook, I saw it looked like he was giving away somebody's laptop at some point.
I think that Brian has the FOAMfrat Amazon login and troubles are brewing.
I mean, we had Oculuses on there and courses, reference cards, stickers. Was that an Arctic cooler I saw on there?
Arctic? I don't know
I think that's how you say it. Arctic.
Arctic. Yeah, those are supposed to be really good. I think those are the competitors from somebody broke off from what's the other really? Everybody knows Igloo. Is that
no, Yeti. Maybe
Yeti. That's the one.
Yeah, Yeti.
Yeah, somebody who broke off from Yeti.
Igloo. I don't think that's that good of a brand. I think that's like the Walmart brand.
Yeah. Well, I thought this episode you did with Shane was really good. I missed his class yesterday, so I was glad that I got to see a little wrap up of it.
Yeah, it was good. We, we're talking about IVCs, but you're not going to talk about just IVCs. So it's really how that fits into the rest of the clinical picture. And I had just done the class that's in studio on is this tachycardia compensatory? I think we called it ultrasound guided pharmacology, about looking at the heart before you decide to do rate control. And then he had done that IVC talk. So I'm like, this fits well to see how you fit that into your exam, because I think it's a secondary data point. It's not something that you look at it and you're like, oh man, I need to do this. The way I look at it is it's really just telling me what the gradient is between the systemic venous pressure and then the right atrial pressure.
So when you think about this, because the main talking point was about, is this patient going to be fluid responsive, which is historically a tough kind of nut to crack, And I was thinking about the IVC and how it's distensible, it can contract or distend with respiration. And I was thinking, the only thing that's going to cause that IVC to dilate or to, move with respiration is going to be the pressure that's inside of it. So you have this volume that's causing this pressure by distensing the IVC that, could be very influenced by, let's say, alpha-1 stimulation or barely at all. And I know that there's a statistically significant correlation between the CVP and the diameter of that IVC. So I know you had just mentioned, or in the podcast, I actually wrote it down. Where was it? You had said that. I liked it, so I wrote it down. Can the LV use it? Can the LV use it, and can the RV handle it? Did I say it backwards?
No, that's right. Yeah. So can the LV use it? So they on the ascending portion of Starling's curve. Yeah.
Yeah. So can the left ventricle use it, and can the right ventricle handle it? And I think that's a good way of looking at that, because you always need to be going a certain way from high pressure to low pressure. So it's got to feed back to the heart adequately. Then the right ventricle, if it can handle it, there's no obstruction in the lungs. Preload for the left side, but does the left side suck? So I thought that was a really good way of looking at that. But how does this play into fluid responsiveness? So if I've got a CVP, let's say you have to choose one and you have to make a case for it. Like somebody says, okay, you can look at the pressure over here, which we know is not good for saying, is a person volume up or volume down, that pressure alone. How does the IVC ultrasound trump that? Why is this better?
I mean, the low-hanging fruit is that it's not invasive, right? So you don't need a pulmonary or a CVP catheter in, Swan-Ganz or whatever. You don't need that in order to tell. So that's probably the big thing. Is this is something that you just put a probe on their chest and you look at it. As far as fluid responsive goes, that's really not what like you said, that's not what you use the CVP or the IVC for. The IVC tells us more when it's not doing what it's supposed to. I mean, it's supposed to collapse. It's supposed to vary with respiration. So when it's not doing that, that gives you a little hint that you need to go searching, further. And the IVC is very easy to get. The view is very easy. So if you're having a hard time getting a cardiac view, you can throw it on the IVC just to start to build up some intuition as to what's going on. Is this elevation in right atrial pressure? Because if that IVC is getting thick, that the gradient between the systemic venous pressure and the right atrial pressure is coming together. And so that is telling you that there's a low flow state as far as preload goes. And so when you see it moving, that really, it doesn't tell you much, right? It doesn't tell you that they need fluid or they need pressors. And I know a lot of people will talk about the CVP when I first got into critical care, that the
Mhm.
CVP tells you whether you need fluid or pressors.
Yeah.
And it doesn't. All it's telling you is that fluid coming back to the heart, and is it moving through the heart in an efficient manner? And if it's not, you're going to back up, and if there's an elevation in thoracic pressure, it's going to back up a little bit. So the CVP just tells you that it's either efficiently going through the heart or it's backing up a little bit. But towards the end of the podcast, I don't know if you heard, I was talking about the pressors. Like,
Mhm.
if they've had multiple liters of fluid and your IVC is still collapsing, that's not necessarily a fluid problem. It's a problem of pressing them in a vasodilatory state, specifically like your septic shock, neurogenic shock. You need to get that fluid back to the heart, and it's the tone of the vasculature that's not letting them do that. So that's
Yeah.
how I reason with the IVC.
Yeah, and I think that what you guys brought out, that you're looking at it at multiple different locations, because you talked about that hepatic vein and how, as you rock that probe cranial, you can see up into the right ventricle, which I think is an interesting data point for doing that exam, because that's one thing that the CVP doesn't give you. You're getting some more subjective things with the ultrasound, but it's interesting because where you'd see it emptying into the right ventricles, like where you'd be measuring your central venous pressure, but then you're also looking further down past that portal vein, and you're seeing these two pressure gradients, which is more along the lines of like what you're talking about, the difference between that systemic filling, means some systemic filling pressure, and that right atrial pressure. So you can see more of the flow from one to the other, more of like the gradient and how the right ventricle is contracting, rather than trying to rely on like one pressure measurement, and you're just looking at your ACXVY and seeing if it's, the descents are proper and stuff like that. It's probably easier to, even though it's probably a little bit more subjective. I don't know, a CVP waveform is subjective too, but I feel like you're getting a lot more data points at one time with that ultrasound, the way you showed doing that exam.
Yeah, and that hepatic vein drains right into the IVC. And so if the pressure is built up within that IVC, it's going to back up into the hepatic system. And so that you talk about, like, you'll see portal vein pulsatility and the nexus criteria for venous congestion. That's because everything starts to back up, and you'll actually see that because the liver sits like right above the IVC when you're looking at this on ultrasound. And so where it would normally drain, everything's starting to dilate out. All those little
Mhm.
ducts are getting dilated, and you can tell when you look at it, like, oh man, they're really congested. And that could be from fluid overload, or it could be just a traffic jam upstream somewhere.
Yeah, it's kind of interesting. I was just thinking about this. So since that portal vein comes right into the IVC, is it almost like getting a long axis and a short axis of the IVC at the same time when you see that portal vein? Like kind of like a surrogate short axis, you know what I'm saying?
Um, maybe,
You don't have to say
maybe.
maybe, it's okay.
I don't. I think you still got to get a short access. It's interesting. I don't. In you didn't see this version, but in the version I edited to put out, I included some pictures and stuff in there, and one of them is showing when you're slicing a circle. Like, if you slice it right down the center, that's that true diameter. But if
Mhm.
you're too close to one side of it, then
Mm,
it can look. It's like the false diameter. It looks like
sure.
it's collapsing, but it's not. So that's why some people will recommend like going short for a little bit. And
Mhm.
also because sometimes the IVC collapses, like not like this, but like this is really
Yeah.
weird. But that's why if you get that short axis, you can tell that. I don't know if you would see all that with the hepatic vein. Um, but that's interesting. Yeah, maybe.
I don't know. Just a
Maybe.
thought. I just bounce these ideas off of you and Cynthia and stuff. I just like to see what you guys come up with, because it's very interesting to me. So, well, awesome episode. And let's check out what Shane has to say. And again, guys, happy EMS week.
Yeah, happy EMS week. We'll see you next time. And Shane O'Donnell, the newest member of the FOAMfrat family. Shane is a flight medic, an educator, and you've been flying for what, 3 years now?
Yeah, 3 years.
Awesome, man. How you liking it?
Oh, I love it. It's an absolute blast. I did some ground critical care before then, and then started flying, like I said, about 3 years ago.
Cool, man. Yeah, Shane, he's been with the FOAMfrat team for how long now? A couple months, three,
Yeah,
four
just a couple
months.
months.
And he just did a talk today on POCUS IVC assessment. was really good. And I sat in actually and watched both of them today because we wanted to do a podcast, a discussion afterwards on whether or not the IVC assessment has a role in pre-hospital ultrasound. And so with your shop, you guys use the Butterfly. Right now, you guys are using ultrasound. And are you guys doing the full EFAST exam?
Yeah, so we're doing EFAST, IVC, cardiac, ocular, airway, and IV access.
And OB, I'm guessing as well.
Yeah, a little bit of OB.
So you guys, anything you can scan, you guys are scanning
Pretty
then,
much.
except for ocular nerve sheaths and stuff.
No, we're
like
doing
that.
ocular nerves too.
No, you're not. Are you
Yeah.
really?
Yeah, try getting that in the aircraft.
Cody will kill me if I mention that. That's awesome. Well, so where does the IVC fit into your assessment? One of the things that comes up when you're talking about pre-hospital ultrasound is how it fits into the actual patient care. You know, you can practice in class and stuff, and okay, probe marker goes towards the right shoulder, or towards the left shoulder, or, you know, it goes down here, and you can get the views. But the question is, like, when I got a crashing patient in front of me, what am I going to do with that ultrasound probe? You know, is there a therapeutic value, and how is that going to help me assess the patient? I know that those are all, you know, pretty heavy loaded questions, but particularly with the IVC, you're obviously not using it in a vacuum. You're probably looking at the heart, lung, IVC, and trying to make decisions as far as cardiac output, venous return, venous congestion. So give me an example of how you would use the IVC view. I'll say that you got a patient that's septic. You walk into the hospital, the blood pressure's in the toilet. It's like, you know, 70/30. They got 2 liters on. They're on Levofed at 0.3 mics per kilo per minute. How are you using ultrasound in that scenario?
Yeah, so the analogy I used for my class was like the heart was New York City or any large traffic burdened city, and the IVC is like these peripheral roads going to it. So if you know your city's jam packed, then your roads are obviously going to suffer from that as well. So when I go in and I'm looking at the IVC first, I'll usually use that like, is it big or is it super small? Like kind of like these extreme ends. And then I know it's big, then my big concern is some sort of obstructive shock. So I'll look at the IVC or I'll look at the heart in the IVC. We can certainly talk about how each of us looks at it just based off of our seating positions where we usually do. But I'll usually look at the IVC and be like, oh, that's really big. I'm concerned about obstructive shock. If the patient's, you know, mechanically ventilated and they're like, oh, they, you know, suddenly got hypoxic a few minutes ago, I might go up to the lungs next and see if it's a big pneumothorax. Or if, you know, this person is a really big concern for cardiogenic shock, then, and if I haven't looked at the heart yet, then I'll take it and go up to the heart. Then if it's small, I'd be concerned about, you know, maybe their volume down or they have a really efficient system that's pulling the blood in. So their heart's, you know, working away, like a young person's heart really well.
Yeah, no, that's very similar to what I do. I think I can tell more about an IVC when it's abnormal, when it's plethoric, when it's thick. Typically, that's greater than that 2.5 centimeters. But it's just like fetal heart rate. It's about the variability as well. You know, are they able to collapse? Typically, it's around 40 to 50% collapsibility. But that also, you need to take into account how hard they're breathing, right? So if you got a sick patient, they can suck hard. They're going to be dropping that thoracic pressure. And, you know, if they're not on like BiPAP or something like that, you could still have a backup in the IVC and still see it collapsing some as well. And so I draw this picture where it's like you got this bucket, and then you got this little conduit, and then you have another bucket over here with like a spigot to like empty the water out. And that whole area here is inside a container that's constantly changing its pressure. And so it takes a lot of backup. You know, you got to have a pretty elevated right atrial pressure for you not to see any fluctuations inside that conduit going from the systemic venous pressure back into the right atrium. And so when you watch that and it is thick and it's not moving, that's telling you that the pressure gradient between the right atrium and the mean systemic filling pressure, the venous system, is like way too close. And so one of the things to like stress is I'll say, all right, imagine I start an IV in your hand and I hook it up to a transducer and I transduce that pressure. It's going to be like 6, 8, I don't know, maybe 10 or so. And then if I looked at the pressure inside your right atrium, that's going to be like 0, 3, I don't know, 5, somewhere in that range. So as long as this pressure is higher than the pressure in the right atrium, you're going to have blood flow back to the heart. But when those pressures start to equalize with each other, they get thick, they get big, and that decreases your preload. And so when I see that, I think of it like like you said, like a traffic jam, right? You're getting ready to get on the on-ramp and you see all these cars backed up and you don't know what the cause is. All you can say is that there's a backup on the highway. So when you see a thick IVC, all you can really say is that there's an elevation in the right atrial pressure. But just like that backup on the freeway, that could be due to construction. It could be due to rush hour. It could be an accident. You don't really know unless you were to actually look at it or, go on Waze and see if they're reporting what the problem is upstream. And so when I see that thick IVC, that tells me that I need to go looking. I need to figure out what is causing this. Is it cardiac in nature? Is it just venous congestion? Do they just get waterboarded at the hospital with, 8 liters of normal saline? So the thick IVC, like you said, it tells us that there's an obstruction likely. All it really tells us is that there's an elevation in right atrial pressure. And we are now getting, as a result, some venous congestion. And you can see like on the liver sometimes, because the liver sits like right above the IVC, you can see like the portal vein and the hepatic vein and those areas start getting real engorged and really big. And I just think of it like the whole venous side is just getting congested over there.
That's the problem. Like when I started doing ultrasound, I was like, the goal is to have this like plump. So you put the probe on somebody and see a really small IVC, and you keep going on the volume until they had like this big. You used to say like you have to swell to get well. The same thing with the IVC, like you have to plump this sucker up, or they're they're still.
I thought that was about the gym. You're right though. That doesn't.
Yeah. That's where it started. So you'd keep going on volume until they got this huge IVC. And then it wasn't until later on that I was like, that's a pathologic state. You should not have an IVC that has no variation when you breathe. That's a problem.
Yeah, that's pretty much like putting a big clamp on it and not allowing it to get back to the heart.
Yeah.
And it's interesting because on the opposite side of that spectrum is the IVC that is collapsing, right? That is, you see the variation, 50% or whatever, but it also depends. Again, the variation is because of them breathing. So if they're just relaxing, they're breathing really slow, like you probably aren't going to see these huge variations in it, but it also shouldn't be very big either. And I remember somebody telling me one time, when you're trying to decide to give somebody volume, you should ask yourself, can the left ventricle use it? And can the right ventricle handle it? And I love that because it's taking into consideration both aspects of the cardiovascular circulation. Is that right ventricle going to be able to handle it and shuttle it over to the left atrium for preload to the left side of the heart? And then if it does, is that left ventricle on the ascending portion of Starling's curve, well, it can actually take that volume and use it to improve stroke volume.
Are you usually measuring the IVC? So, you put the probe on and you're like, hey, this is small. Are you measuring that variation, either on scene or when you're flying? Have you found success with that?
Yeah, I'll take a picture of it and a video of it just because I want to get like the actual measurement just for whatever. And then I also get a video because you can't really you can show variation if you do an M-line tracing. So let's get into that. So here is the IVC. You got the right atrium over here. And you want to measure about 1 to 3 centimeters from the right atrium. So right where this line is, and this is the hepatic vein. And you want to be over on the left side of the hepatic vein. Now, if you're in abdominal mode, the right atrium is going to be on the other side of the screen, and the hepatic vein will be here, so that you'll actually be measuring on the right side of it. But you just want to go on the other side of that hepatic vein, and that's where you want to look at and measure. Now, if you're going to actually trace it, and you want to get a picture and measure it at the same time, or show variability and measure, you can drop your M line right down the middle of it. and then look at it during inhalation and during exhalation. So during inhalation, you're going to get one measurement. During exhalation, you're going to get the other. And then you want to see if that's about 50% of that collapsibility. So I like this method. Here's an actual picture of it. So you can see inspiration and expiration. The problem is they're not breathing real hard. Then you don't really see it that much. But I don't know. It's probably pays to still actually measure it. There's a lot of subjective things in EMS. So probably the more objective we can make things, the problem is just getting people to actually want to pull out the calipers on there and scroll it down and measure it. And the other aspect is when you're looking at the IVC, you're bisecting a circle, so you could hit it right along like this one side, like right here, and it could look like it's collapsed, when in reality, if you moved it over a little bit or you fanned it, you would see that it's actually full. And so one of the things I tell people to do is when you're looking at the IVC, you want to fan it. And so fan it is moving it like this, and then rocking it would be this way. So I'll hold it and I'll fan it and just kind of go through the different layers, almost like you would on like a CT scan, where you're like looking through the different layers just to make sure you're not missing anything. Do you do that as well?
Yeah, and it seems like we do our initial exam of the IVC a little bit different, because I know you like to do subxiphoid view and then flip your probe around, right?
Right. Yeah.
I usually, and it's just based off of where I'm sitting, so I'm usually at the patient's head, so I have to, like, doing that hand wrist turn thing is really hard from where I'm seated, so I'm usually able to get at using an abdominal mode. So sometimes the images you'll see will be flipped one way or the other, and you can do the same measurements and everything's just reversed, just based off of what mode you're seeing. But I'm often having to do an abdominal mode because I can't reach that flip. And if I'm sitting next to the patient, that's one thing, but you may see that the image looks a little reversed, and that's why.
Yeah, that's a good point. What else was I was going to say? Oh, tracing it back to the right atrium is super important, because you can accidentally get the aorta in view and be like, oh man, look at this thick double C IVC. And it's actually the aorta. So that's one of the reasons why I like to do like subxiphoid, and then I watch it turn into the IVC as I turn it. But as long as you're tracing that back to the right atrium, just to make sure it's not the aorta. So that's a just good technique to do, is to make sure you trace that back as well.
And if you put the probe on and you're like, I don't know which one this is, then just find the other one. So if I put it on and I angle it a little bit and I'm like, I think this is the IVC, but it's a little pulsatile just because the vibrations from the heart, then I'll just turn my probe, maneuver a little bit to the left, and then be like, oh yeah, there's the aorta. These are two different structures to help identify that.
Yeah, and typically like the liver, so this like gray area here is the liver. Typically that liver is like right above the IVC. So if you don't see that, then that should be another sign that you're probably not in the right area. It also is a good idea to flip it in the transverse view as well, in the short axis, just to make sure you are not bisecting that circle and thinking it's collapsing, when in reality maybe it's collapsing this way instead of this way. And I didn't know that could happen. Dr. Spiegel was on 5 Minute Sono. He was talking about that, how he'll look at it in the short axis, because sometimes the IVC can go this way instead of this way. And you can think that it's not collapsing, but you're just not seeing it. So really quick, hitting a short axis view of it, I think is it's super easy to do, and it'll allow you to have that bigger picture. All right, here's my, oh, sorry, go ahead.
The nice part with the short axis is you can differentiate too. Be like, oh, there's the aorta. Go midline on the IVC and turn right over it.
Now, the other thing I wanted to hit on before we wrap this up is the idea that if you have a septic patient that has gotten like 2 to 3 liters of fluid, and they have a IVC that is collapsing, 60, 70% or so, there is a tendency to think that they need volume before you can start pressors. And something that I think it was a blog by Josh Farkas, and there's been a couple people who have done papers on this as well, showing that, sepsis is a vasodilatory state. And so you can give people volume, but it needs to get back to the heart. And so if the tone of the vasculature is relaxed, you're not squeezing it back up to the heart. And so you're essentially trying to like fill them up with volume to make up for the lack of tonicity. And so I think that after you have like 2 liters, a liter and a half, 2 liters on, I have a pretty low threshold to start hanging some Levofed to try to restore that tone, especially if they don't have a reason to be total volume down. If they're just third spacing because of this vasodilatory state, then starting them on some Levofed, you may see that IVC start to get a little bit thicker just because now you're able to bring that fluid back to the heart. You're taking that unstressed volume, turning it into stressed volume, and allowing that venous return. So it's a little pet peeve because I have heard people say, oh, I see it collapsing. We can't start pressors. We have to wait until the IVC is not collapsing in order to give pressors, because that still means their volume down. And that's just, their volume down, the volume's down in their feet. We got to get it back up to their heart.
And they may have a really efficient heart. Like if you have an 18-year-old who's septic, then you may not get him, you are going to have a lot of variation until he's in, fulminant pulmonary edema, because you have to fill the IVC so much before you're not going to see any variation because of how efficient somebody's heart can be.
Yeah, no, totally. Awesome, man. Well, Shane, thanks so much, dude. It's great having you on the team. Any closing thoughts? Anything we're forgetting?
No, this has been awesome. Thanks, man.
Cool. All right, guys, we will be back next week. I don't know what Sam wants to talk about, but it'll be good. And once again, happy EMS week. Talk to you guys soon.